So, chapter 8 is on skeletal system pathophysiology, and hopefully, I've divided it up into four smaller parts, kind of the same general things together. Hopefully, it makes sense to you. So, first, we're going to talk about bone trauma and fractures, pretty common, commonly seen. The learning objectives, these are for the whole chapter, not just for this section of it. And these you can read these in Canvas as well. So fractures, the definition of a fracture, it's a break in bone continuity, whether it's a complete break or an incomplete break. Traumatic fractures are the most common types of fractures from falls or accidents or sports or high impact activities. Intentional injuries can be something where somebody uh, another person intentionally breaks your arm. Hopefully that never happens. Or an activity that you intentionally took on that ended up in a fracture. Pathological fractures, on the other hand, if you have weak bones from osteoporosis or from other pathological reasons, you can have commonly spine, hip, wrist, or foot fractures. Minimal trauma is required. Sometimes it's something as small as sneezing or trying to open a stuck window can cause spinal compression fractures in people with osteoporosis. The interesting thing that I heard in a class that I took about osteoporosis is 50% of women and 25% of men will have an osteoporotic fracture in their lifetime. So it's not just women. A lot of times you think of women with osteoporosis, but older women, it tends to be in the hip or spine or wrist. Um, and older men, more hip and spine, just statistically speaking. We can think of reasons why this is true. So the key risk factors for fractures are decreased bone density, balance and coordination deficits. So as we get older, that could play into it. Alcohol and tobacco use, poor nutrition or high risk activities. One time I was working in the hospital and I think it was around a holiday. I don't remember, it's a long time ago, but there was someone who had fallen and at a family event and broken their ankle and wrist. And it was opposite, so like left ankle, right wrist, made it really challenging to get them mobile. But the family swore up and down that person had been drinking, and the person swore up and down that they had not been drinking. So it's a risk factor. Poor nutrition because you're not don't have the bone building nutrients, or high risk activities like base jumping or something. I don't know. I'm sure you can think of other high risk activities. So those are risk factors for fractures. Fractures are classified primarily by whether they're open versus closed. So open is the skin's broken, and of course there's a higher infection risk because our outer barrier is broken, or closed where the skin's not broken. And displaced versus non-displaced. If the bones are displaced, it requires reduction, meaning putting the bones back into place. If they're non-displaced, then usually just support, protection is all that is required. So there are special considerations to consider with fractures, any type of fractures. If pediatric patients break their epiphyseal plates, which are near the ends of their long bones, their growth plate fractures can stunt growth just in the injured limb. So that can cause problems later on. Non-union is where a fracture fails to heal after 9 to 12 months. That tends to happen more in patients with comorbidities or older patients with osteoporosis that just don't have the bone building going on. So those are special types of fractures. Each fracture is classified by kind of how it is in the how it is in the inside the break. So a spiral fracture is a twisting injury, and the spiral is just how it sounds. So that's the third from the right in this picture. So you get a twisting injury. Comminuted means there's multiple fragments, and usually, like I usually think of comminuted as being shattered, but really, comminuted just means there's more than one break in the same bone. So you could have, like, say that you fall on your bike and you break your wrist, and there are two fracture lines. That's considered a comminuted fracture. Impacted, the bone ends are crushed together. Green stick, usually in children, the bone bends and one side sort of cracks a little bit, and but the other side is intact. Because children's bones are bendier. They don't fracture as easily, they're not as brittle. An avulsion fracture is where a tendon pulls a bone fragment from the bone. So that's no fun. Stress fractures result from repetitive loading. So foot bone fractures are common stress fracture areas. If someone, I worked with someone who worked in a building that had concrete floors, and also lived someplace with hard floors and walked to work. And so they had repetitive loading on their feet, and ended up with stress fractures in their metatarsals. And the solution was they had to get more supportive cushioning shoes because they were always on hard surfaces. So bone healing, I always say circulation equals healing, and bones got great circulation because our bones are like our calcium or mineral checking account. So, like the savings account, you're just always putting things in and it's building up. The checking account, you put things in and you take it out, and you put things in and you take it out. So, your bones are your mineral checking account because your body needs a constant supply of calcium, phosphorus, and other minerals, and the bones are where we store them. So, we need a good blood supply so we can keep putting calcium in and taking calcium out. So because it has a good blood supply, it also heals well. Handy, right? So there are stages of healing. The first stage is the hematoma formation, where a blood clot forms between the bone fragments. And that's usually in the first week. The proliferation stage is where proliferation is always creation of new cells. So the fibroblasts are in there just spitting out new cells and new tissues, and you get a callus that forms. Sometimes people call this the soft callus stage in the first 2 to 3 weeks. It's sort of like the scar tissue phase. The fibroblasts are laying down collagen to mend the bones together. Stage 3 is the bony callus stage, and some people call this the hard callus stage. And it's generally 6 to 8 weeks in adults, 3 to 4 weeks in children. Children heal faster, they just do. Being young is a good way to heal. And this fourth stage is remodeling. And so in the bony callus stage, you have the fibrocartilaginous structure that's being filled in now with calcium. Stage 4 is the remodeling stage, which can take up to 18 months to complete. The adult bone strength is generally strong enough for normal forces at about 12 weeks post-fracture. So healing from fractures, you generally heal pretty fast. Pediatric has faster healing, and they get a hard callus at 3 to 4 weeks. So kids can be out there running around pretty soon after their fracture, sooner than you would expect, usually. So some factors that can delay bone healing, lifestyle factors, which of course we know are changeable, modifiable. Tobacco use slows it down, alcohol use slows it down, inadequate nutrition slows it down. Some medications, like corticosteroids, slow down the deposition of calcium, and so they delay bone healing. Medical factors can include infection, malunion, where the bone ends don't go together well, diabetes, because it affects the small blood vessels, and that affects your healing. Osteoporosis, because your osteoblasts just aren't putting out that calcium. Lack of weight bearing. Wolff's law is bones respond to the stresses we put on them. Remember that from kinesiology? So if you don't put stress on those bones, they are not going to build up. So there's a certain stage in healing where you have to put protected stress on the bones. And general immobilization, if you stay completely immobile, your bones are not going to heal as easily. So it's going to delay bone healing. Fracture management, generally, the bone ends aren't together, a reduction is required. So reduction is where you put the bone ends together. External reduction is a manual realignment of the bones, and that can be done if the bones are pretty close together to begin with. The open reduction is a surgical realignment. So you'll see the abbreviation ORIF, which means open reduction, internal fixation. And the internal fixation is hardware. So they put in screws and bolts and plates and whatnot to hold your bones together. So usually they're immobilized by casting or splinting. It's far more common these days to see a soft cast rather than a hard plaster cast or fiberglass cast. Removable soft casts are preferred. Internal fixation is where you have hardware inside, and external fixation is where you have hardware supports outside. So the interesting thing about external fixation is usually see it in the hospital, um, very rarely outside the hospital, and you are more susceptible to infection because you have openings where the external fixation is going through your skin. The goals of fracture management are to get the bones aligned properly and promote healing, to prevent complications like infection, and then, of course, to restore function. Compartment syndrome is a myofascial syndrome that is a medical emergency because you can end up losing a limb. You lose circulation and innervation, and you can end up losing a limb. Severe pain, paresthesia, and or numbness. So paresthesia is the feelings are not right. You get numbness, loss of sensation. It's most common in the forearm or the leg. If you have someone who is in a cast, in a soft cast, or has had a previous fracture and has these signs and symptoms, we need to immediately refer them back to their physician. We need to closely document their symptoms. We need to discontinue treatment. Compartment syndrome can lead to amputation if left untreated. So it's part of the cause of compartment syndrome isn't really clearly known, but the fascia start to really tighten around the injured area, and it actually cuts off circulation and nerve innervation. So in the surgery that they do for compartment syndrome, they open up the fascia to release the pressure inside the compartment. Because as we learned in kinesiology, the forearm muscles and the lower leg muscles are all closely packed in there together. Those fascial sheaths around them, if they get too tight, it can cause a lot of compression and cause problems. And so if they're not treated adequately, it can lead to amputation because you get tissue necrosis. And if it's to the point where it can't be saved, well, then you end up with an amputation, and you just don't want to get there. A bone bruise or a contusion is bone damage with intact trabeculae. So those are the little bone structures inside the bone. A bone bruise isn't visible on an X-ray. Sometimes you can see it on an MRI. There's bleeding around the bone. 2 to 3 month healing process. Treatment with protection, rest, ice, compression, and elevation are typical treatment for inflammation. And in PT, we help maintain the range of motion and strength of the joints in the area and the muscles in the area with a bone bruise. If you're a little kid and you get a bone bruise because somebody threw a shot put at your ankle, not intentionally, but it happens. Um, then usually they put you on crutches. That's the rice part, the rest part of rice, and then just monitor you. An adult might need a little bit more intervention. Children don't need intervention for simple orthopedic injuries because they heal so quickly. Adults might need a little more nudge to get back on the right track. So in physical therapy, we're going to do, in the acute phase, we're going to do our RICE protocol, or PRICE protocol, if you want that. Pain management modalities, so it might be ice, electrical stim, any of the modalities that we use for pain management, patient education, and a safety assessment. A lot of times in the emergency room, we're doing crutch training or assistive device training, and we're assessing their safety and balance. In the progressive phase where they are starting to get better, we're doing now, they're in outpatient PT usually, we're doing range of motion exercises, progressive strengthening, and gait training, and then progressing their assistive devices. So maybe they started out with crutches, maybe we're going to a single crutch, maybe we're going to a cane or a less restrictive assistive device. Once the outer part is healed, if they had an open reduction internal fixation or external fixation, we might have them in the pool for limited weight bearing gait training. It's a lovely way to treat someone with limited weight bearing. In advanced rehabilitation, we're doing proprioceptive training, we're retraining balance, we're doing functional training. Maybe we're doing some return to activity preparation, whether it's return to sport or return to their profession, and fall prevention education. We don't want to re-break the part that's not quite as strong as the other parts. So our critical responsibilities during the physical therapy period are to monitor pain and sensation because we want to avoid things like compartment syndrome. We want to recognize the symptoms of compartment syndrome or blood clots. We want to educate the patient on healing factors. So those factors that we talked about that can delay healing, we want to educate the patient about that and how they can progress their healing. And a lot of times, a lot of orthopedic surgeons have particular protocols that they like to follow, and it's our responsibility to progress per those protocols.